In the living fabric of the body, where every cell strives for harmony and survival, there exists a primal drama, an ancient defense that rises whenever injury strikes or an invader intrudes. This drama is called inflammation. Contrary to the common tongue, where inflammation is often uttered with dread, as though it were a malevolent affliction, the truth is nobler. Inflammation is not our foe. It is in fact one of our oldest allies, an indispensable protector without which wounds would fester, microbes would ravage unchecked, and tissues would never find repair. Inflammation is the story of the body's resilience. In its heart, inflammation is a response of vascularized tissues, a summoning of warriors from the bloodstream, leukocytes, antibodies, complement proteins, and an arsenal of chemical mediators delivered to the site of injury or infection. These soldiers, normally silent and quiescent in the circulating river of blood, are called into action by the trumpet of danger. Some are already stationed in tissues, ever-vigilant sentinels, awaiting the moment of alarm. Once roused, they converge upon the battlefield to perform three sacred tasks: recognition of the invader, recruitment of defenders, and removal of the threat. And when their purpose is served, they must withdraw, allowing the landscape to heal. Without inflammation, there would be no survival. With it, we rid ourselves not only of the inciting insult, the microbe, the toxin, the splinter, but also of the consequences of injury, necrotic cells, debris, and festering tissue. Yet, this powerful ally is a double-edged sword. The very fire that burns away the intruder can also singe the host. And when misdirected or uncontrolled, inflammation becomes the author of disease itself. Thus, even as inflammation protects us, it is also the fountainhead of some of humanity's most devastating chronic maladies. And it is for this reason that our pharmacies overflow with anti-inflammatory drugs, designed to temper the flames without extinguishing the essential protective spark. The SRs of inflammation. The entire saga of inflammation can be remembered through 5 steps, often called the 5 Rs. 1. Recognition of the injurious agent, the sentinel's alarm. 2. Recruitment of leukocytes, the mustering of forces. 3. Removal of the offender, destruction and clearance. 4. Regulation of the response, the extinguishing of the fire once victory is won. 5. Repair of damaged tissue, healing through regeneration or the laying down of scar. This sequence plays out in every inflammatory episode, whether the foe is a single bacterium or a gaping wound. Components of the response. The stage upon which this drama unfolds consists chiefly of 2 actors: vascular vessels, which dilate, become more permeable, and alter their endothelial linings to allow passage of defenders; leukocytes, which adhere, migrate, engulf, and destroy. Together, the vascular and cellular reactions, under the orchestration of soluble mediators, give birth to the phenomenon we call inflammation. But with every defense comes the risk of collateral damage. The release of reactive oxygen species, nitric oxide, proteolytic enzymes, and cytokines may ravage not only the invader, but also the innocent host tissues. In most instances, these flames are self-limiting, dying down as the injury resolves. Yet, when the fire persists, or when it is misdirected against one's own body, the story turns tragic. The perils of misguided inflammation. In the annals of medicine, one finds countless disorders where inflammation itself is the villain. Autoimmune diseases arise when the immune system turns its sword against self-tissues. Allergies erupt when harmless dust, pollen, or food becomes the false enemy. Chronic smoldering inflammation drives diseases as grave as atherosclerosis, type 2 diabetes, Alzheimer's disease, pulmonary fibrosis, and even cancer. So wide-ranging are its consequences that the lay press has aptly, if melodramatically, christened it the silent killer. Thus, Even as inflammation protects us, it is also the fountainhead of some of humanity's most devastating chronic maladies. And it is for this reason that our pharmacies overflow with anti-inflammatory drugs, designed to temper the flames without extinguishing the essential protective spark. Acute and chronic inflammation. Traditionally, inflammation is divided into two great types. Acute inflammation, the rapid first response, arising within minutes or hours, lasting for hours to a few days. It is marked by exudation of plasma proteins, edema, and the swift arrival of neutrophils, the shock troops of host defense. If the enemy is vanquished quickly, the storm subsides and healing ensues. Chronic inflammation, in contrast, is the slow-burning fire. It may follow unresolved acute inflammation or arise de novo against difficult foes, tubercle bacilli, viruses, fungi, and even self-antigens. Chronic inflammation lingers for weeks, months, even years, characterized by the relentless presence of macrophages, lymphocytes, and fibrosis. Where acute inflammation is a skirmish, chronic inflammation is a siege, often causing more damage than the original invader. Historical highlights. The recognition of inflammation as a clinical phenomenon stretches far into antiquity. As early as 3000 BC, an Egyptian papyrus described its features. But it was Celsus, the Roman encyclopedist of the 1st century AD, who immortalized the 4 cardinal signs: rubor, tumor, calor, dolor. Centuries later, in the 19th century, Rudolf Virchow added a 5th, functionaliza, loss of function. In 1793, the Scottish surgeon John Hunter declared what is now axiomatic: inflammation is not a disease, but a salutary response, an attempt at healing. In the 1880s, the Russian biologist Ali Mechnikov observed phagocytosis in starfish larvae and mammalian leukocytes, concluding that the purpose of inflammation is to bring phagocytes to the scene, to engulf and destroy invaders. His discovery, which earned him a Nobel Prize, inspired both admiration and satire. George Bernard Shaw, in The Doctor's Dilemma, mocked the medical cure-all of stimulating the phagocytes. Finally, Sir Thomas Lewis, through his studies of skin reactions, demonstrated that chemical mediators like histamine orchestrate vascular changes. His work laid the foundation for the modern understanding of mediators of inflammation and the therapeutic power of anti-inflammatory drugs. Thus, from papyrus to modern immunology, the story of inflammation is as old as medicine itself. Causes of inflammation. What then awakens this mighty response? The triggers are many, yet they can be gathered under 4 broad banners. 1. Infections and microbial toxins, the most common and clinically important causes. Bacteria, viruses, fungi, parasites, and their toxins can elicit every variety of inflammatory reaction, from mild and transient to fulminant and fatal. 2. Tissue necrosis, regardless of its cause. Ischemia, trauma, burns, frostbite, irradiation, chemical injury. Death of tissue is a clarion call for inflammation, for the body must swiftly clear the necrotic remnants. 3. Foreign bodies, whether splinters, dirt, or sutures. Even endogenous crystals can become irritants: urate crystals in gout, cholesterol crystals in atherosclerosis, and lipids in obesity-associated metabolic syndrome. 4. Immune reactions, or hypersensitivity, where the immune system itself causes harm. Autoimmune diseases direct the immune arsenal against self-tissues. Allergies target innocuous substances like pollen or food, and persistent immune responses create chronic inflammation. Here, the fire is fanned by cytokines, especially those from T lymphocytes. Each of these stimuli, infectious, necrotic, foreign, or immunological, sets the inflammatory machinery into motion, calling forth the same sequence of recognition, recruitment, removal, regulation, and repair. Closing of Section 1. Thus ends the prologue to our great narrative on inflammation. We have seen that it is both a protector and a destroyer, an ancient sentinel that ensures survival, yet one that, if unchecked, can turn upon its own master. We have witnessed its cardinal signs, its historical discovery, and the diverse causes that summon it. From here, we march forward to the mechanisms of recognition, the molecular eyes and ears that detect invaders and necrotic cells, and set the stage for the fierce vascular and cellular responses of acute inflammation. Section 2. Recognition of microbes and damaged cells. Before the body can rally its defenders, before blood vessels dilate, and before the white armies pour into the tissue, there must be an act of recognition. The drama of inflammation begins not with thunder, but with perception. It begins when certain vigilant cells, stationed like watchmen in every organ, sense the presence of danger, whether that danger be an invading microbe or the silent debris of a dying cell. Recognition is the opening spark that ignites the conflagration of inflammation. Every cell is endowed with the ability to perceive alterations in its environment, yet certain cells are especially trained to act as sentinels: macrophages, dendritic cells, epithelial guardians, and other leukocytes. These cells carry on their surfaces and within their depths a remarkable armamentarium of receptors, molecular eyes and ears that survey the landscape of the body. The most celebrated among these are the toll-like receptors, molecules first uncovered in fruit flies, now known to be present in humans, arranged along plasma membranes, endosomes, and even within the cytosol. Their position is strategic, for microbes may lurk outside, may be engulfed into vesicles, or may hide within the very cytoplasm of the host cell. Wherever they may be found, toll-like receptors stand ready to bind the distinctive molecular patterns of invaders: lipopolysaccharides of bacterial walls, double-stranded RNA of viruses, unmethylated CpG motifs of microbial DNA. The moment such a pattern is sensed, cascades of intracellular signals are set in motion, culminating in the release of cytokines, chemokines, and adhesion molecules. The alarm is sounded, and the inflammatory orchestra begins to play. Yet, it is not only foreign invaders that can rouse this alarm. Even our own cells, when mortally wounded, release signals that are read as distress calls. In the cytoplasm of every cell lie receptors known as NOD-like receptors, capable of perceiving molecules liberated by cell death: uric acid from the shattering of DNA, adenosine triphosphate released from mitochondria torn apart, and even the subtle drop in intracellular potassium that accompanies membrane rupture. When such signs are detected, the NOD-like receptors assemble into a dramatic molecular complex called the inflammasome. This formidable structure acts as a fuse, leading to the generation of interleukin-1, a powerful cytokine that summons waves of leukocytes into the battlefield. Sometimes, however, the machinery itself betrays the host. Rare mutations that render these receptors overactive give rise to autoinflammatory syndromes, disorders in which interleukin-1 is spewed forth relentlessly, kindling inflammation even in the absence of any foe. For these sufferers, the fire is quenched only by medicines that block interleukin-1, proof that even our innate defense can turn treacherous when misregulated. The inflammasome, though originally designed as a sentinel against cellular demise, has been implicated in many modern plagues. It reacts fiercely to urate crystals in gout, to cholesterol crystals within atherosclerotic arteries, to lipid accumulations in obesity and diabetes, and even to amyloid deposits in the brains of those with Alzheimer's disease. In each instance, the body mistakes its own debris for hostile invaders, unleashing a storm of inflammation that contributes to chronic, debilitating illness. Thus, the act of recognition, once so crucial for survival against pathogens, can paradoxically drive the pathology of civilization's most common maladies. Other systems also aid in this perception. Leukocytes are armed with receptors that recognize the tail regions of antibodies, known as Fc receptors, and with receptors for complement proteins. When a microbe has been coated with antibodies or complement fragments, a process called opsonization, these receptors allow phagocytes to seize it with ease, binding and internalizing the marked foe. In this way, adaptive immunity and innate inflammation merge seamlessly, one enhancing the other. Nor is recognition confined to the cellular realm alone. The blood itself is laced with soluble proteins that drift like scouts through the circulation. Chief among them is the complement system, a cascade of plasma proteins that, upon activation, not only marks microbes for destruction, but also liberates potent inflammatory mediators. Alongside complement float lectins, such as mannose-binding lectin, and the family of collectins, molecules that recognize microbial sugars and initiate defense. These soluble sentinels extend the reach of the inflammatory system far beyond the boundaries of individual cells, ensuring that no intruder in the bloodstream escapes notice. Thus, recognition is not the work of a single molecule or cell, but the combined vigilance of many. The toll-like receptors stationed on membranes, the NOD-like receptors vigilant in the cytosol, the inflammasome awaiting its moment to flare, the Fc and complement receptors on leukocytes that bind marked prey, and the soluble proteins of the blood that patrol continuously. Together, these guardians form an intricate web of surveillance, allowing the body to detect threats in every compartment it possesses. This act of perception is more than passive sensing. It is the decisive first move of inflammation. For once the danger is perceived, mediators are secreted, vessels are prepared to dilate, adhesion molecules are displayed, and leukocytes begin their journey out of the circulation. The ancient wheel of inflammation begins to turn. Recognition, then, is the key that unlocks the inflammatory cascade, the indispensable opening act without which the host would remain blind to its enemies and helpless before its injuries. And so, having witnessed how the body perceives danger, we stand at the threshold of action. The alarm has been raised, the mediators begin to flow, and the bloodstream stirs with gathering defenders. In the next movement of this narrative, we shall enter the heart of battle itself, exploring the vascular changes and cellular migrations that characterize acute inflammation, the rapid, often dramatic first phase of the inflammatory response.
Section 3. Acute inflammation, vascular and cellular events. Acute inflammation is the body's trumpet blast of urgency. Unlike the slow simmer of chronic inflammation, acute inflammation is swift, erupting within minutes or hours, lasting days at most, and designed to deliver defenders to the front lines with haste. Its hallmarks are the leakage of plasma proteins from the circulation, the swelling of tissues with exudate, and, above all, the arrival of neutrophils, the shock troops of host defense. The vascular changes. The first visible act of acute inflammation is played upon the stage of the microcirculation. Within moments of injury or infection, arterioles dilate, engorging capillary beds with rushing blood. This phenomenon, called hyperemia, gives rise to the redness and warmth that Celsus observed centuries ago. The dilation is not arbitrary, but carefully mediated. Histamine released from mast cells, nitric oxide generated by endothelial cells, and other vasoactive mediators loosen the vascular tone, opening the gates to a torrent of blood. Yet the drama deepens when the vessels, once tight and selective, now begin to leak. The normally seamless endothelium becomes permeable, allowing plasma proteins to pour into the interstitial spaces. This leakage occurs through several mechanisms. Sometimes endothelial cells contract swiftly, pulling apart at their junctions, creating transient gaps through which proteins escape. At other times, mediators such as vascular endothelial growth factor induce more enduring reorganization of the cytoskeleton, prolonging the passage of plasma. In severe injury, endothelial cells may be burned, blasted, or torn away altogether, leaving great rents through which plasma floods. The result is the formation of an exudate, a protein-rich fluid that distinguishes inflammatory edema from the transudates of non-inflammatory states. With the proteins comes fibrinogen, which polymerizes into fibrin, creating scaffolds within the tissue. Immunoglobulins seep out as well, arming the tissue with soluble defenders. The swelling, or tumor, that Celsus described is the visible testament to this vascular exodus. Not only do vessels leak, they also alter their flow. Initially, there is a fleeting vasoconstriction, so rapid it is often unnoticed, followed by arteriolar dilation and engorgement of capillaries. The increased permeability slows the stream, and, as plasma leaves, the remaining blood becomes concentrated. The viscosity rises, the flow becomes sluggish, and leukocytes tumble toward the vessel walls in a process known as stasis. Endothelial cells, now activated by cytokines such as interleukin-1 and tumor necrosis factor, display adhesion molecules upon their surfaces. It is here, in this quieting river, that the great recruitment of leukocytes begins. The cellular events. Recruitment of leukocytes. Recruitment is not a chaotic rush, but a highly choreographed ballet. The first act is margination, where leukocytes, pushed by hydrodynamic forces, drift from the central column of flowing blood toward the endothelial surface. There, they begin to roll, tethered lightly by selectins, P-selectin, E-selectin, and their ligands, which create fleeting bonds, broken and reformed with every pulse of the heart. Under the microscope, one may see these cells tumble like dancers skimming across the stage. Rolling soon gives way to firmer attachment, as integrins on the leukocyte surface change from low affinity to high affinity states under the influence of chemokines displayed on endothelial proteoglycans. These integrins, such as LFA1 and MAC1, bind tightly to immunoglobulin family molecules like ICAM1 and VCAM1 on the endothelium. The leukocyte, once a transient roller, now adheres with firmness, arrested against the vessel wall. But the true passage lies beyond. The leukocyte must transverse the endothelium in a process called transmigration or diapedesis. Squeezing between endothelial junctions, guided by molecules such as PECHAM1 expressed on both leukocyte and endothelial cells, the cell emerges into the extravascular space. The basement membrane is breached with the help of collagenases, and the leukocyte sets foot in the tissue. Once free, the cell does not wander aimlessly, but follows gradients of chemoattractants, a phenomenon called chemotaxis. These gradients may be formed by bacterial products like N-formylated peptides, by components of the complement cascade, such as C5a, or by leukotrienes and chemokines secreted by host cells. Along these invisible scent trails, the leukocyte marches unerringly toward the focus of injury or infection. In acute inflammation, the first to arrive are neutrophils. Within the first 6 to 24 hours, they dominate the battlefield, drawn swiftly by chemotactic factors and armed with granules containing potent enzymes. About a day, monocytes take their place, maturing into macrophages in the tissues. The sequence is logical. Neutrophils are rapid responders, but short-lived. Monocytes come later, more enduring, and with greater versatility. Phagocytosis and microbial killing. When leukocytes encounter their prey, a new phase begins, the engulfment and destruction of the offender.
Microbes and debris are often coated by opsonins, molecules like immunoglobulin G and fragments of complement that mark them for phagocytosis. Leukocytes bind to these opsonins through Fc and complement receptors, forming a tight embrace. Engulfment proceeds with the extension of pseudopods, which encircle the particle and draw it inward into a vesicle known as a phagosome. Lysosomes, rich in hydrolytic enzymes, then merge with the phagosome, creating the phagolysosome, a deadly chamber where the microbe meets its end. The killing within is multifaceted. The most fearsome weapons are reactive oxygen species, generated through the respiratory burst of the NADPH oxidase system. Superoxide anion is formed, converted to hydrogen peroxide, and further transformed into hydroxyl radicals, each more destructive than the last. Myeloperoxidase in neutrophil granules catalyzes the production of hypochlorous radical, a bleach-like molecule of extraordinary potency. Alongside these oxidants comes nitric oxide, synthesized by inducible nitric oxide synthase, which itself is toxic and also combines with superoxide to form peroxynitrite. Collateral damage and termination. Yet, in the ferocity of their assault, leukocytes do not always distinguish between friend and foe. Their oxidants and enzymes may leak into the extracellular space, damaging host tissues. This is the essence of tissue injury in many inflammatory diseases. The very cells meant to defend us become, in their zeal, our accidental tormentors. Fortunately, the inflammatory storm does not rage forever. Built into the response are mechanisms of resolution. As the stimulus is eliminated, the production of pro-inflammatory mediators wanes, while anti-inflammatory signals rise. Lipid mediators switch from leukotrienes to lipoxins. Cytokines like transforming growth factor beta and interleukin-10 are secreted, and apoptotic neutrophils are cleared by macrophages. Thus, the blaze is gradually extinguished, leaving behind a tissue poised either for regeneration or for repair by scarring. Closing of Section 3, Part 1. Here we pause in the saga of acute inflammation. We have seen the opening vascular overture, the slowing blood, the adhesion and migration of leukocytes, their chemotactic march, and their fiery destruction of microbes. Yet the story is not complete, for acute inflammation is not only a tale of cells and vessels, but of the chemical messengers that guide them. In the next movement, we shall enter the vast kingdom of mediators of inflammation, exploring histamine, prostaglandins, leukotrienes, cytokines, and complement, the chemical signals that conduct this fiery symphony.
Section 3 continued, Mediators of Inflammation. Inflammation is not a random flurry of events. It is a carefully orchestrated performance, each step cued by signals whispered from one cell to another or unleashed from plasma proteins that course through the blood. These signals, called mediators, appear in the earliest seconds of injury and vanish once their work is done. They are often produced only when needed, secreted in bursts from mast cells, platelets, neutrophils, macrophages, or hepatocytes. They may act on a single neighboring cell or flood through the circulation to touch distant organs. Some provoke vasodilation, others summon leukocytes, others still kill microbes or set limits to the response. Each mediator acts with purpose, and together they weave the fabric of acute inflammation. Vasoactive amines, histamine and serotonin. The swiftest mediator to appear is histamine, stored in preformed granules of mast cells scattered beneath epithelia and around vessels, ready to be released within seconds of injury. When trauma strikes, when complement fragments like C3A and C5A appear, or when binding of antibodies triggers degranulation,
histamine pours forth. Its effects are immediate: arteriolar dilation, increased permeability of venules, endothelial contraction. This accounts for the earliest vascular changes of inflammation. Though fleeting in action, histamine's role is profound, for it sets the stage upon which later mediators play. Serotonin, stored mainly in platelet granules, acts similarly, causing vasoconstriction in some contexts, vasodilation, and permeability in others. Though less prominent than histamine, serotonin adds its own note to the early inflammatory chorus. Arachidonic acid metabolites, prostaglandins, and leukotrienes. If histamine is the opening cry, then the derivatives of arachidonic acid are the prolonged anthem of inflammation. Arachidonic acid, a polyunsaturated fatty acid lodged in cell membrane phospholipids, is released by the action of phospholipase A2 whenever cells are activated. Once free, it is transformed by two major enzymatic pathways: the cyclooxygenase pathway, producing prostaglandins and thromboxane, and the lipooxygenase pathway, yielding leukotrienes and lipoxins. Prostaglandins are versatile messengers. Prostaglandin E2, along with prostacyclin, causes vasodilation and contributes to the redness and warmth of inflamed tissue. They sensitize nerve endings to bradykinin and other pain mediators, explaining the dollar of inflammation. Thromboxane A2, generated by platelets, promotes vasoconstriction and platelet aggregation. Prostaglandins also mediate fever, for when pyrogenic cytokines induce cyclooxygenase in the hypothalamus, prostaglandins reset the body's thermostat upward. Leukotrienes, formed via 5-lipooxygenase in leukocytes, are potent spasmogens and chemoattractants. Leukotrienes C4, D4, and E4 constrict bronchial smooth muscle and increase vascular permeability, their excess contributing to the wheezing of asthma. Leukotriene B4 is a powerful recruiter of neutrophils, guiding them towards sites of infection. Balancing this pro-inflammatory tide are the lipoxins, also derived from arachidonic acid, but serving as natural brakes. Lipoxin A4 and B4 inhibit neutrophil recruitment and chemotaxis, promoting resolution. The same substrate that feeds the flames of inflammation can, by another pathway, quench them. It is upon this understanding that many of our most used drugs rest. Aspirin and other non-steroidal anti-inflammatory agents inhibit cyclooxygenases, suppressing prostaglandin synthesis. Newer drugs target leukotriene pathways in asthma. Thus, by manipulating these mediators, medicine has learned to temper the fiery orchestra. Cytokines and chemokines. Whereas prostaglandins act swiftly and locally, cytokines are the more articulate messengers, proteins that carry nuanced instructions from one cell to another. Among them, tumor necrosis factor and interleukin-1 stand as towering figures. Secreted chiefly by macrophages and dendritic cells in response to microbial products, they activate endothelial cells to express adhesion molecules, increase permeability, and produce chemokines. They induce fever, stimulate production of acute-phase proteins in the liver, and at high levels contribute to septic shock. Interleukin-6, another cytokine, is a major inducer of hepatic acute-phase responses. Interleukin-17, produced by T lymphocytes, mobilizes neutrophils and monocytes, linking innate and adaptive immunity. And countless chemokines, small proteins with the sole mission of guiding leukocyte migration, establish gradients along which neutrophils and monocytes march. Some chemokines are constitutive, ensuring steady homing of lymphocytes to lymphoid tissues, while others are inducible, creating highways of inflammation in infected organs. The complement system. Even as cells secrete mediators, The plasma itself is alive with the complement cascade, a chain of more than 20 proteins that lie in wait, ready to be activated by microbes or antibodies. Once triggered, complement splits and expands through 3 converging pathways: the classical, the alternative, and the lectin pathway. All meet at the cleavage of C3, releasing C3a, a fragment that increases vascular permeability and acts as an anaphylactoxin, and C3b, a fragment that optonizes microbes for phagocytosis. The cascade proceeds to generate C5a, one of the most powerful chemoattractants known, and finally the membrane attack complex, which punctures microbial membranes like a spear. Thus, the complement system is both a mediator of inflammation and a direct killer of microbes. Other mediators. The blood harbors other cascades as well. The kinin system, activated by factor 12, generates bradykinin, which increases vascular permeability, causes contraction of smooth muscle, dilates vessels, and induces pain. The clotting system not only stops bleeding, but also provides fibrinopeptides that increase vascular permeability and serve as chemotactic agents. The fibrinolytic system breaks down clots, producing plasmin, which can activate complement and generate fibrin split products that influence vascular permeability. Each cascade, though designed for hemostasis or repair, also converses with the language of inflammation. Regulation and redundancy. Though diverse, the mediators share common traits. They are generated only in response to stimuli, act briefly, and are tightly regulated, for unchecked activity would devastate host tissues. Many have overlapping functions, so that blocking one may not halt inflammation entirely. This redundancy ensures survival, but also makes therapeutic targeting a delicate art. Closing of Section 3, Part 2. Thus we have traversed the realm of chemical mediators, from the lightning-fast strike of histamine to the prolonged symphony of prostaglandins and leukotrienes, from the commanding voices of cytokines to the cascading fury of complement and kinins. Each acts alone, yet they are all woven together into the grand design of acute inflammation. Our story now approaches its morphological phase, where the biochemical and cellular battles leave visible marks in tissue, the patterns of serous, fibrinous, suppurative, and ulcerative inflammation. And beyond these patterns lie the possible destinies of acute inflammation: resolution, scarring, or descent into chronicity.
Section 3. Continued. Morphologic patterns and outcomes of acute inflammation. When inflammation erupts, its fury is not only molecular but also sculptural, carving visible forms into tissues. These patterns, though diverse, all bear the common features of vascular dilation, increased permeability, and leukocyte infiltration. Yet the balance of fluid, fibrin, pus, and necrosis creates distinct landscapes. The simplest and often most transient form is the serous inflammation, in which a thin, watery fluid exudes from plasma or from secretions of mesothelial cells lining the peritoneal, pleural, or pericardial cavities. A burned blister upon the skin or the effusion within a viral pleuritis are familiar examples. The fluid is not laden with cells, but clear, its accumulation separating tissues into delicate vesicles. More dramatic is the fibrinous inflammation, where vascular leaks are large and fibrinogen escapes into the tissues. There it polymerizes into fibrin, coating serosal surfaces with shaggy strands. Upon the pericardium, such fibrin deposits may produce the roughened surfaces that physicians describe as a friction rub. Microscopically, one sees eosinophilic threads of fibrin enmeshing leukocytes. If the fibrin is not removed by fibrinolysis and macrophages, it may organize into scar tissue, converting delicate serosal membranes into dense adhesions with serious functional consequences.
Then comes the suppurative, or purulent inflammation, the archetype of bacterial infection, especially by pyogenic organisms like staphylococci. Here the tissue is transformed into a pus-filled battlefield, the exudate rich in neutrophils, necrotic debris, and edema fluid. Abscesses are the quintessential form, circumscribed collections of pus within an organ, often enclosed by a fibrous wall if chronicity sets in. The central liquefactive necrosis is encircled by viable neutrophils, beyond which granulation tissue may begin to wall off the focus. Separation is the body's desperate effort to contain a virulent foe, though often at the cost of tissue destruction. Lastly, there is the ulcer, a local defect of the surface of an organ or tissue produced by the sloughing of inflamed necrotic tissue. Ulcers arise on epithelial surfaces, such as the skin, the gastric mucosa, or the duodenum. They represent the most destructive culmination of acute inflammation, where necrosis penetrates deeply, leaving behind a breach in continuity. Microscopically, the ulcer shows an acute inflammatory border at its base and margins rich in neutrophils, while the deeper layer often reveals granulation tissue and scarring. Ulceration is both a wound and a window, exposing the ferocity of inflammation upon a surface once whole. From these morphologic guises, we turn to the destinies of acute inflammation. The ideal outcome is complete resolution, where the offending agent is eliminated, the exudate cleared, and the tissue architecture fully restored. Such resolution is possible when the injury is limited, the tissue has regenerative capacity, and the inflammatory process is swiftly terminated. It is the happy ending, the return to normalcy, as though the drama had never occurred. But often, the play ends otherwise. If the tissue is destroyed beyond repair, or if fibrinous exudates organize, the result is scarring or fibrosis. Here, connective tissue grows into the damaged area, forming dense scars that replace function with permanence. In some organs, such as the heart after a fibrinous pericarditis, scarring may tether surfaces and impair motion. In others, it may be silent, yet irrevocable. And sometimes the story does not end at all, but passes into another chronicle. When the acute response fails to clear the invader, when the injurious stimulus persists, or when immune mechanisms themselves perpetuate injury, the outcome is progression to chronic inflammation. In this transformation, the neutrophils give way to macrophages and lymphocytes. Fibrosis accumulates, and the acute blaze becomes a smoldering fire. Many diseases, from tuberculosis to rheumatoid arthritis, owe their persistence to this grim continuation. Thus, the outcomes of acute inflammation, resolution, scarring, or chronicity, depend not on destiny but on the balance of forces, the virulence of the offender, the resilience of the host tissue, and the efficiency with which the inflammatory orchestra performs and withdraws.
Closing of Section 3. And so ends the tale of acute inflammation. We have seen vessels dilate and leak, leukocytes roll and migrate, mediators signal and amplify, pus accumulate and ulcers gnaw. We have traced the possible outcomes: return to health, replacement by scar, or transition into chronic disease. Acute inflammation is a storm, sometimes cleansing, sometimes destructive, always dramatic. The stage is now set for the longer chronicle, chronic inflammation, where the brief skirmish becomes a protracted siege, where macrophages, lymphocytes, and fibrosis dominate, and where the line between defense and disease blurs. Section 4. Chronic inflammation. Chronic inflammation is not simply prolonged acute inflammation. It is a qualitatively distinct process, defined by the simultaneous presence of ongoing inflammation, tissue injury, and attempts at healing. It arises in three broad circumstances: when acute inflammation fails to clear a persistent infection, when immune-mediated diseases kindle continuous flames, or when injurious agents such as silica or cholesterol persist in tissues and cannot be removed.
In each case, the battle ceases to be a swift skirmish and becomes an enduring siege. The cellular composition of chronic inflammation differs profoundly from that of the acute response. Where neutrophils once dominated, now macrophages, lymphocytes, and plasma cells preside. Fibroblasts lay down collagen and new vessels sprout in the attempt to heal. The tissue becomes a patchwork of ongoing injury and repair, an uneasy coexistence of destruction and creation. The causes of chronic inflammation. The first and most classical cause is persistent infection, often by microbes that resist eradication. Mycobacteria, such as the tubercle bacillus, viruses that linger within cells, fungi and parasites that outlast the immune response, all may provoke chronic inflammation. Such infections often evoke delayed type hypersensitivity and granulomatous reactions, the most specialized form of chronic inflammation. The second great cause is hypersensitivity diseases, in which the immune system itself becomes a source of injury. Autoimmune diseases such as rheumatoid arthritis or multiple sclerosis arise when the immune system mistakes self for non-self, sustaining chronic inflammation without external stimulus. Allergic diseases, in which the immune system reacts inappropriately to harmless environmental antigens, also fall into this category. Here, the stimulus is not persistent microbe, but persistent immune response. The third cause is prolonged exposure to potentially toxic agents, whether exogenous or endogenous. Silica dust inhaled by miners lingers in the lungs, inciting chronic silicosis. Excess lipids within arterial walls foster atherosclerosis, where chronic inflammation fuels the progression of plaques. In such cases, the agent cannot be removed and the inflammation cannot resolve. The cellular clayers. Central to chronic inflammation are the macrophages, descendants of monocytes that stream from the blood into tissues. Once within the tissue, monocytes differentiate, enlarge, and acquire enhanced abilities to phagocytose and to secrete a staggering array of mediators. They release cytokines that sustain inflammation, growth factors that stimulate fibroblasts and angiogenesis, and enzymes that degrade tissue. When activated, macrophages may destroy microbes, but they may also wreak havoc on the host's own structures. Macrophages do not act alone. Lymphocytes are their constant partners. Activated T cells secrete cytokines that recruit and activate macrophages, while macrophages present antigens and produce cytokines that activate T cells in turn. This mutual reinforcement creates a cycle of persistent inflammation. B lymphocytes and plasma cells add their own contribution, producing antibodies that may target microbes, or, in autoimmune disease, the host itself. Other cells join this chronic community. Eosinophils, prominent in allergic disease and parasitic infections, release major basic protein that damages epithelia. Mast cells, laden with histamine and proteases, participate not only in immediate hypersensitivity, but also in the orchestration of chronic reactions. Even neutrophils, though hallmarks of acute inflammation, may appear in chronic lesions when persistent stimuli provoke continuous recruitment. The morphology of chronic inflammation. Histologically, chronic inflammation is recognized by infiltration with mononuclear cells, destruction of tissue by the inflammatory process, and attempts at healing by connective tissue replacement. Microscopically, one sees macrophages, lymphocytes, and plasma cells scattered amidst necrotic debris, fibroblastic proliferation, and newly formed vessels. The architecture of the tissue is distorted, sometimes subtly, sometimes grotesquely. Among the special forms of chronic inflammation, none is more distinctive than the granulomatous inflammation. A granuloma is a collection of activated macrophages that assume epithelioid appearance, sometimes fusing into multinucleated giant cells. These structures arise when the immune system attempts to wall off a substance it cannot eradicate. Granulomas are seen in tuberculosis, leprosy, syphilis, cat scratch disease, sarcoid, and in reactions to foreign bodies. In tuberculosis, for instance, the epithelioid macrophages cluster into well-defined granulomas with central caseous necrosis, their ghostly cheese-like centers surrounded by lymphocytes. In sarcoid disease, granulomas form without necrosis, their epithelioid cells neatly arranged, often with giant cells studded with asteroid bodies. In foreign body granulomas, the culprit is inert material such as sutures or silica particles, recognized not by T-cell-mediated immunity, but by direct macrophage response. Granulomas, though striking under the microscope, embody the paradox of chronic inflammation. They are the body's effort to contain and sequester, yet they also distort and scar, interfering with normal function. In the lung, fibrotic healing of granulomas may cripple respiration. In lymph nodes, they may destroy architecture. In arteries, they may occlude flow. The outcomes of chronic inflammation. Just as acute inflammation has its possible resolutions, so too does chronic inflammation end in varied ways. Ideally, if the offending agent is removed, the inflammatory cycle may subside and healing may restore function. More commonly, however, chronic inflammation leads to fibrosis, the replacement of functional parenchyma with scar tissue. This fibrosis may cause organ failure, as in cirrhosis of the liver or pulmonary fibrosis. In some cases, chronic inflammation underlies neoplasia. For the continuous cycle of cell turnover, DNA damage, and cytokine-driven proliferation provides fertile soil for cancer. Gastric carcinoma after Helicobacter pylori gastritis or colonic carcinoma after ulcerative colitis are grave examples. Thus, chronic inflammation is not merely a prolongation of acute inflammation. It is a distinct, insidious process, sculpted by macrophages and lymphocytes, capable of protecting against invaders, yet equally capable of crippling the host. It is the embodiment of the double-edged sword, the proof that what preserves life in the short term may diminish it in the long. Closing of Section 4. Here ends our journey through chronic inflammation. We have seen its causes: persistent infections, immune disorders, and indigestible agents. We have met its cellular denizens: macrophages, lymphocytes, plasma cells, eosinophils, and mast cells. We have traced its morphologic forms, from diffuse mononuclear infiltrates to the sculpted granuloma, and we have understood its outcomes: fibrosis, organ failure, and even malignant transformation. But the story of inflammation does not rest here, for while local battles rage within tissues, the whole organism often feels the consequences. Fever, malaise, elevated acute-phase proteins, and metabolic changes are the systemic manifestations of inflammation, the subject to which we now turn.
Section 5. Systemic effects of inflammation. Inflammation, though born of local insult, often manifests in distant organs, as if the entire body rallies in sympathy with the injured part. These manifestations, formerly called the acute-phase response, now recognized as systemic inflammatory response, are mediated by cytokines coursing through the circulation, chiefly tumor necrosis factor, interleukin-1, and interleukin-6. Their effects are manifold, reaching brain, liver, marrow, muscle, and fat. Fever. The most universal systemic sign is fever. The elevation of body temperature, though seemingly detrimental, is in fact a carefully calibrated defense. Pyrogenic cytokines, especially IL-1 and TNF, stimulate cyclooxygenase activity in vascular and perivascular cells of the hypothalamus. This leads to increased production of prostaglandins, notably PGE2, which reset the hypothalamic thermostat to a higher point. The body then generates heat through vasoconstriction and shivering and conserves it by reducing sweating until the new temperature is reached. Fever, though uncomfortable, confers advantage. It impairs replication of some microbes and enhances immune reactions. Yet excessive fever may be dangerous, and in sepsis, where cytokines flood the system, fever may spiral into life-threatening hyperpyrexia. Acute-phase proteins.
In the liver, cytokines induce the synthesis of acute-phase proteins, a group of plasma proteins whose levels rise markedly in inflammation. Among them, C-reactive protein, CRP, and serum amyloid A protein, SAA, act as opsins and activate complement, thereby enhancing microbial clearance. Persistently high SAA, however, can deposit as amyloid, causing secondary amyloidosis. Another acute-phase protein is fibrinogen, which binds to red blood cells, causing them to stack into rouleaux that sediment rapidly. This phenomenon underlines the erythrocyte sedimentation rate, ESR, a simple but valuable clinical marker of systemic inflammation. These proteins serve as both instruments of defense and indicators for clinicians, their rising levels signaling the presence and intensity of inflammation. Leukocytosis. The bone marrow too is stirred into action. Under the influence of colony-stimulating factors and cytokines, the marrow accelerates its release of leukocytes, producing leukocytosis, often raising counts to 15 or 20,000 per microliter, and in some infections to extraordinary levels exceeding 40 or 50,000, a condition termed leukemoid reaction. The pattern of leukocytosis hints at the nature of the inflammatory stimulus. Neutrophilia accompanies bacterial infections, often with a left shift showing increased immature forms. Lymphocytosis points toward viral infections. Eosinophilia heralds allergic reactions or parasitic infestations. Thus, the blood count becomes a mirror of the body's ongoing struggle. Other systemic manifestations. Beyond fever, acute-phase proteins, and leukocytosis, inflammation alters many facets of physiology. Tachycardia and increased blood pressure arise from cytokine effects on the heart and vessels. Rigors, chills, anorexia, malaise, and somnolence reflect the hypothalamic and central nervous system actions of IL-1 and TNF. In septic shock, where cytokines surge uncontrollably, catastrophic outcomes ensue: disseminated intravascular coagulation, metabolic derangements, hypotension, and multi-organ failure. Even metabolism is reshaped. TNF, sometimes called cachectin, induces wasting of fat and muscle in chronic infections and malignancy, contributing to the syndrome of cachexia. What began as a defense becomes, in excess, a drain upon the body's strength. Closing of Section 5. Thus, the drama of inflammation, though sparked in a single tissue, echoes throughout the entire organism. Fever warms the body as it struggles against invaders. The liver sends forth proteins that arm defenses. The marrow dispatches legions of leukocytes. The hypothalamus and muscle induce fatigue and rest. These systemic manifestations are both allies and adversaries, essential to survival, yet potentially fatal when unchecked.
Section 6. Tissue repair, regeneration, and healing by fibrosis. Injury is universal, but the destiny of an injured tissue is not sealed at the moment of insult. What follows is the process of repair, the attempt of the body to restore integrity and function. Repair may take two forms. When injury is slight and the surviving parenchyma retains proliferative capacity, the tissue may undergo regeneration, restoring normal structure with almost miraculous fidelity. But when injury is severe or the tissue lacks regenerative ability, the wound heals by fibrosis, in which connective tissue replaces lost parenchyma, forming a scar. Most often, both regeneration and scarring occur together in varying proportions, each shaping the final outcome. General principles of cell proliferation and tissue regeneration. The capacity of a tissue to regenerate depends upon the intrinsic proliferative abilities of its cells. Robbins divides the body into three great categories: labile tissues, such as hematopoietic cells, and epithelia of the skin, gastrointestinal tract, and genourinary tract, are in constant renewal, with stem cells cycling to replace the lost. These tissues can regenerate readily if their stem cell pools remain intact. Stable tissues, such as the parenchyma of liver, kidney, and pancreas, as well as endothelial cells, fibroblasts, and smooth mesenchymal cells, are normally quiescent. They remain in the G0 phase of the cell cycle, dividing only rarely.
Yet, when stimulated by injury or loss of tissue, they can proliferate and contribute to repair. The liver is the classical exemplar. Even after removal of 2/3 of its mass, it can regenerate fully, provided the connective tissue scaffold is preserved. Finally, there are permanent tissues, such as neurons of the central nervous system and cardiac myocytes. These cells are terminally differentiated, incapable of division. Injuries to brain or heart cannot be reversed by regeneration, and healing in these organs invariably proceeds through scarring. Control of cell proliferation. Regeneration is not a random burst of growth, but is tightly controlled by growth factors and interactions with the extracellular matrix. Polypeptide growth factors secreted by macrophages, platelets, fibroblasts, and other cells bind to receptors and trigger signaling cascades that drive cells' entry into the cell cycle. Epidermal growth factor, hepatocyte growth factor, vascular endothelial growth factor, platelet-derived growth factor, fibroblast growth factor, transforming growth factor beta, all have pivotal roles. The extracellular matrix provides not only structural scaffolding, but also signals that influence cell behavior. Integrins binding to matrix proteins activate pathways that promote survival, proliferation, and differentiation. Loss of the matrix scaffold often prevents perfect regeneration, forcing repair to proceed by fibrosis. Regeneration of the liver. The liver provides a magnificent demonstration of regeneration. Following partial hepatectomy, hepatocytes re-enter the cell cycle under the influence of growth factors such as hepatocyte growth factor and IL-6. Within days, the organ restores its mass. This regenerative capacity is unique, yet even here there are limits. Chronic injury, as in viral hepatitis or alcohol-induced damage, replaces regenerative cycles with scarring and cirrhosis, where nodules of hepatocytes are encased in fibrous bands. Repair by connective tissue, scar formation. When regeneration cannot suffice, repair proceeds by the deposition of connective tissue, culminating in scar formation. This process unfolds in sequential steps. The first step is the formation of granulation tissue, a term that belies its delicacy and beauty. Under the microscope, granulation tissue appears as a pink, soft, granular surface composed of proliferating fibroblasts, loose connective tissue, and newly formed capillaries, all embedded in an edematous extracellular matrix. This tissue is fragile but vibrant, representing the early scaffold upon which a stable scar will later be built. Central to granulation tissue is angiogenesis, the sprouting of new vessels from pre-existing ones. Endothelial cells, stimulated by vascular endothelial growth factor, proliferate and migrate into the wound, forming leaky capillaries that nourish the growing tissue. Parasites and smooth muscle cells later stabilize these vessels, converting the delicate sprouts into mature channels. Alongside angiogenesis proceeds the migration and proliferation of fibroblasts, driven by growth factors such as PDG factor and FG factor. Fibroblasts deposit collagen and other extracellular matrix components, weaving the framework of the scar. At first, the collagen is type 3, thin and delicate, but with time, it is remodeled into type 1 collagen, thick and strong, giving tensile strength to the healed tissue. As the scar matures, the vascularity of the granulation tissue diminishes, the edema subsides, and fibroblasts become quiescent. What remains is a pale, avascular scar, composed chiefly of dense collagen, capable of holding tissue together, but incapable of restoring original function. Remodeling of connective tissue. Scar tissue is not static. Matrix metalloproteinases, secreted by fibroblasts, macrophages, and endothelial cells, continuously remodel the extracellular matrix, balancing synthesis with degradation. This remodeling determines the final strength and appearance of the scar. Normal healing restores about 70 to 80% of the original tensile strength of unwounded skin, but never achieves complete restoration. Factors influencing repair. Many influences alter the pace and quality of repair. Infection is the most important, prolonging inflammation and delaying healing. Nutrition also plays a role. Vitamin C deficiency impairs collagen synthesis, producing weak scars. Glucocorticoids, with their anti-inflammatory effects, may reduce fibrosis, but at the cost of poor wound strength. Mechanical factors, such as tension on the wound, may pull it apart. Poor perfusion from arterial disease or diabetes slows healing, and systemic conditions like diabetes or uremia are notorious impediments. Wound healing in practice. Wounds heal in one of two principal ways. Healing by first intention or primary union occurs when a clean surgical incision with closely opposed edges heals. Here, minimal tissue is lost, and the sequence of events, clock formation, epithelial regeneration, granulation tissue, and scar, is orderly and efficient. Healing by second intention or secondary union occurs when the wound is large, the edges gaping, and significant tissue is lost. In such wounds, more intense inflammation, abundant granulation tissue, extensive angiogenesis, and large scars ensue. Wound contraction mediated by myofibroblasts may dramatically reduce the size of the defect, but never without distortion. Pathologic aspects of repair. Healing is not always benign. Excessive deposition of collagen produces hypertrophic scars or keloids, where the scar grows beyond the boundaries of the original wound, sometimes grotesquely. Exuberant granulation tissue, or proud flesh, protrudes above the wound surface, hindering epithelial closure. Contractures, especially in burns, distort joints and impair mobility. And in internal organs, excessive fibrosis underlies many chronic diseases, from cirrhosis to pulmonary fibrosis, where repair becomes pathology. Closing of Section 6. Thus, repair completes the saga of inflammation. Where tissues are young and labile, regeneration can restore them to their pristine state, as if the injury had never occurred. Where injury is severe or tissues are permanent, scars form, weaving collagen to bind what was torn, though never restoring what was lost. And where repair itself runs amok, pathology arises anew. Inflammation and repair together embody the eternal cycle of injury and healing, destruction and creation. They remind us that the human body, though fragile, is endowed with remarkable powers of renewal, yet also that every healing bears the mark of imperfection, a scar, a reminder of the battles fought.